Hello, my name is Ashley Williamson, and this is my presentation on pheochromocytoma. The chief complaint for our patient today. A Caucasian female patient, age 40, presents with episodes of severe headaches, palpitations, sweating, and high blood pressure. These symptoms have been intermittent over the past few months, but have recently increased in frequency and severity. She reports episodes of feeling extremely anxious, flushed, and dizzy, often without an obvious trigger. Some more information on our patient. She has a past medical history of hypertension diagnosed 3 years ago. Previously managed with lifestyle modifications and a low-dose beta blocker, her hypertension has become increasingly resistant to treatment. She reports intermittent migraines for the past several years, controlled with over-the-counter analgesics and the occasional prescription migraine medication. She has mild anxiety managed with without medication, and reports that her current anxiety episodes feel different from her past experiences. She has an allergy to penicillin. It caused her rash, but does not report anaphylactic reaction. She has no food or environmental allergies. Her social history. She works as an office administrator and reports moderate stress levels at work. She's a lifelong non-smoker and drinks approximately 2 glasses of wine per month socially. She drinks 1 to 2 cups of coffee per day, and she exercises 3 to 5 times a week, doing primarily walking and yoga. She has no history of recreational drug use. Her surgical history includes appendectomy at age 22 with an uncomplicated recovery, and her second child was born by a cesarean section and is now 12 years old. She did not have any post-operative issues. Her family history includes hypertension and type 2 diabetes in her father. Her mother, deceased at age 65 from myocardial infarction, also had a history of high blood pressure. She has one brother who is alive, age 45, with no known health issues. There is also no known history of pheochromocytoma or other adrenal gland disorders, but there is a noted prevalence of cardiovascular conditions. Her current medications are metoprolol succinate 50 milligrams for hypertension management taken once daily. She takes sumatriptan 100 milligrams as needed for migraines. Over-the-counter supplements include a daily multivitamin, a daily vitamin D recommended by her primary care provider due to low vitamin D levels, and magnesium 400 milligrams taken in the evening to help with migraine prevention and relaxation. Some differential diagnoses that are important to note for pheochromocytoma. It does present the same way as these diagnoses and is often overlooked. Essential hypertension presents as headaches, dizziness, palpitations, anxiety, blurred vision, and fatigue. Panic disorder, palpitations, sweating, chest pain, nausea, shortness of breath, and dizziness. Hyperthyroidism can present with tachycardia, hypertension, sweating, tremors, anxiety, and fatigue. Carcinoid syndrome can present with blood pressure fluctuation, flushing, tachycardia, anxiety, wheezing, and dizziness. In pheochromocytoma, the difference is the episodic surges in blood pressure, palpitations, sweating, headaches, anxiety, nausea, and vomiting. Pheochromocytoma PCC overview. PCC is a rare neuroendocrine tumor originating from chromatin cells in the adrenal medulla. It is caused by an excess catecholamine secretion, primarily norepinephrine and epinephrine. It occurs in a small number of patients with hypertension. It causes an increased sympathetic response leading to hypertension, tachycardia, and hyperglycemia. Other signs and symptoms include headaches, diaphoresis, anxiety or panic, pallor or flushing. It can be potentially life-threatening due to hypertensive crisis if untreated, so it is very important to diagnose. In this case, the chief complaint of episodic symptoms, particularly with hypertension, palpitations, sweating, and headaches, points to pheochromocytoma as a likely diagnosis. Further testing, such as plasma or urine catecholamines, and imaging results and studies typically indicate and confirm the diagnosis and localize the tumor. We will explore some of these diagnostic tests later in the presentation. First, let's learn more about pathophysiology and clinical manifestations of the disease process across the lifespan. The origin of pheochromocytoma. Pheochromocytomas arise from chromaffin cells that form the tissue of the adrenal medulla, the inner part of the adrenal glands, located on top of the kidneys. A part of the sympathetic nervous system, chromaffin cells synthesize, store, and release catecholamines, primarily norepinephrine and epinephrine. It also monitors oxygen and carbon dioxide levels and helps regulate blood pressure and respirations. Abnormal proliferation of chromaffin cells form a tumor that produces and releases excessive amounts of catecholamines. The uncontrolled chromaffin cell growth can be triggered by genetic mutations, alterations in proto-oncogenes, and growth factor dysregulation. The tumors can be familial or originate sporadically. The catecholamine effects. Norepinephrine and epinephrine act on alpha and beta adrenergic receptors, causing widespread sympathetic activation, triggering the fight or flight response, even in the absence of an actual trigger. The alpha-1 receptors found in vascular smooth muscles cause vasoconstriction, leading to hypertension. The ryanodine 2 receptors control the release of calcium to the cytoplasm from the sarcoplasmic reticulum and trigger and regulate muscle contraction. Beta-1 receptors stimulate and initiate a cascade of activity in the cells of the SA and AV nodes, resulting in increased heart rate and contractility. Beta-2 receptors cause vasodilation in skeletal muscles and bronchodilation, causing peripheral effects like tremors and sweating. Sympathetic nervous system dysregulation. Catecholamine overproduction leads to episodic sympathetic spikes, hypertension, palpitations, and anxiety. The sustained hypertension in chronic cases, catecholamines can alter vascular tone, leading to persistent hypertension. Unlike normal adrenal medullary cells, chromaffin cells and pheochromocytoma tumors are not subject to usual feedback mechanisms. This leads to unregulated episodic secretion of catecholamines, resulting in a sudden fight or flight response, even in the absence of stressors. The effects of glucose metabolism. Hyperglycemia. Catecholamines increase glucose production by stimulating glycogenolysis and gluconeogenesis while decreasing glucose uptake in tissues. This effect is part of the fight or flight response, but can lead to episodic hyperglycemia. Cardiac and vascular complications from chronic catecholamine exposure can cause damage to blood vessels and can lead to cardiomyopathy, arrhythmias, and myocardial ischemia from prolonged hypertension, and increase the risk of aneurysm or stroke. Associated genetic mutations, approximately 30 to 40 of pheochromocytomas are linked to genetic mutations and syndromes. Multiple endocrine neoplasia type 2, von Hippel-Lindau syndrome, neurofibromatosis type 1, and succinate dehydrogenase mutations. These mutations may result in altered cellular metabolism, increased oxidative stress, and unchecked cell growth, contributing to the tumor formation and unregulated catecholamine production. A summary of the pathophysiological effects of PCC. Episodic and sustained hypertension due to alpha-adrenergic effects, tachycardia and palpitations resulting from beta-adrenergic effects on cardiac tissue, sweating and anxiety caused by general sympathetic activation, and metabolic effects like hyperglycemia due to increased glucose production and lipolysis. The clinical manifestations across the lifespan. In infants and young children, PCC is rare, but can present in association with genetic syndromes. Some symptoms are sustained hypertension and is often the primary sign, detected incidentally or due to symptoms like irritability or lethargy. Behavioral changes such as unexplained crying or irritability, poor feeding, and sweating. Paleness or flushing are seen in episodic pallor or redness due to catecholamine surges. Additional manifestations are failure to thrive caused by chronic hypertension or metabolic stress that may impact growth and weight gain. Seizures can occur with severe hypertensive crises. In adolescence, there's an increased prevalence in children with familial syndromes like MEN2, VHL, or NF1 who may develop PCC. Symptoms include hypertension, which is often episodic but can be sustained. Adolescents may report headaches, dizziness, or blurred vision. The classic triad may present as headaches, palpitations, and sweating, either paroxysmal or persistent. Anxiety-like symptoms may exhibit anxiety, panic attacks, or behavioral changes due to excess catecholamines. Growth and development can be affected. Delayed puberty or stunted growth due to chronic illness may delay growth milestones. Secondary symptoms like recurrent headaches, weight loss, and decreased energy level can also contribute to abnormal growth. In adults, this is the time of peak incidence, age 30 to 50. They're mostly diagnosed at this age. Paroxysmal hypertension, blood pressure spikes with episodes of severe headaches, sweating, and palpitations. Persistent hypertension, in around 50% of cases, present with sustained high blood pressure, especially if undiagnosed. The classic triad might also present here and includes headaches, palpitations, and diaphoresis. Hyperglycemia can present as glucose intolerance or incidental hyperglycemia. Other weight loss or other symptoms including weight loss due to elevated metabolic rate and potential anorexia, orthostatic hypotension, episodic catecholamine surges followed by lows that can cause blood pressure drops, and familial syndromes in patients with inherited mutations often present earlier and have bilateral tumors. There may also be neuropsychiatric symptoms like anxiety, panic attacks, or mood swings. In older adults, age 60 and greater, there's a lower incidence, but the disease can be severe if undiagnosed or untreated. There's usually an atypical presentation, and symptoms may be mistaken for other cardiovascular or metabolic conditions that are common in older adults. Symptoms like hypertension complications, higher risk of heart disease, stroke, or aneurysms due to prolonged hypertension, fatigue and weight loss, often less specific and may be attributed to aging. Orthostatic hypotension, more pronounced due to autonomic dysfunction and age-related blood pressure variability. Blunted classic symptoms. The classic triad may be less evident, with symptoms more often related to complications like atrial fibrillation, heart failure, or angina. Impact on comorbidities, like worsened cardiovascular disease. The catecholamine excess can exacerbate pre-existing cardiac conditions. And in diabetes, the aggravation of glucose control in diabetic patients due to catecholamine-induced hyperglycemia. Laboratory and diagnostic evaluation. Biochemical testing is the primary diagnostic tool. Plasma-free metanephrine labs, 24-hour urine fraction metanephrines and catecholamines are used, and imaging studies like CT, MRI, and MIBG scintigraphy are used to localize the tumor. Genetic testing for hereditary syndromes is done if indicated. Additional testing to rule out differential diagnoses include clonidine suppression test, thyroid function test, and serum control, cortisol. In this case, the findings were elevated plasma metanephrines and catecholamines. The adrenal protocol CT scan with contrast demonstrated a well-delimited solid mass with marked enhancement. And the genetic results in this case were negative for a mutation in genes associated with familial pheochromocytoma. For management and treatment, adrenalectomy surgery is the only curative treatment. It is the standard of care for patients who are surgical candidates. Minimally invasive surgery is favored over open procedures. In perioperative management, the alpha blockade such as phenoxybenzamine is prescribed for 7 to 14 days prior to surgery to control blood pressure and prevent hypertensive crisis. Managing hemodynamics instability is the main concern intraoperatively. Close monitoring of blood pressure and blood pressure control are imperative for continued stabilization postoperatively. Targeted therapy options in patients with malignant and metastatic disease, which are 10 to 20% of PCC patients, are being explored in clinical trials and are directed at checkpoint inhibitors to help control the cell growth rate. Ablation and palliative care, including radiofrequency ablation, cryoablation, and embolization are used to suppress tumor growth. Cultural and sociocultural considerations. In health literacy and awareness, there are cultural perceptions of symptoms like palpitation or anxiety that may lead to delayed presentation in some communities, as symptoms are sometimes stigmatized or attributed to non-medical causes like nerves or stress. In some populations, lack of awareness or rare conditions like PCC can lead to delays in seeking specialized care or obtaining an accurate diagnosis. Access to healthcare and socioeconomic barriers include cost of diagnostic tests and specialist consultations that can be prohibited for underinsured or uninsured patients. Patients in rural or underserved areas may have limited access to endocrinologists or facilities equipped to perform specific laboratory or imaging studies. Cultural beliefs about surgery and medications may also affect treatment. In some cultures, they have specific beliefs about surgery that may affect acceptance, particularly when surgical removal of the adrenal gland is suggested. The alpha blockers and beta blockers that are essential in preoperative care and patients with cultural concerns about Western medicine may need more education and support to understand the importance of the medications. Genetic testing and counseling may be required for those with inherited forms of pheochromocytoma. Some cultures may be resistant to genetic testing due to privacy concerns or beliefs regarding hereditary diseases. Family-centered decision-making is important in some cultures, and understanding this can improve adherence to treatment plans and follow-up. Prognosis. Early detection and treatment. Favorable outcomes with early diagnosis. When diagnosed early and managed surgically, prognosis is generally good, with a 5-year survival rate exceeding 90% for a benign case. Malignant pheochromocytoma. About 10% of cases are malignant with a worse prognosis. In these cases, survival rates vary widely depending on the extent of metastasis. The impacts of delayed diagnosis. Delayed diagnosis can result in long-term cardiovascular damage, increasing the risk of complications like myocardial infarction, heart failure, or stroke. Recurrence rates are approximately 10 to 15%, emphasizing the importance of long-term follow-up. In familial syndromes, there's an increased risk of recurrence. Patients with genetic forms of PCC may have bilateral tumors or develop additional tumors over time. Monitoring for other tumors. Genetic syndromes like MEN2 or VHL increase the risk of other tumors, as seen in medullary thyroid carcinoma and renal cell carcinoma, and require ongoing surveillance. The expected health outcomes, teaching, and anticipatory guidance. In postoperative recovery, most patients experience normalization of blood pressure post-surgery. However, some may require continued antihypertensive therapy. Symptoms like headaches, sweating, and palpitations generally resolve after successful tumor removal. Long-term management. Lifelong monitoring of plasma metanephrines and blood pressure is crucial to early detection of recurrence, especially in those with hereditary PCC. Managing and maintaining control of comorbid conditions like cardiovascular disease or glucose intolerance is important for quality of life. After treatment, patients generally return to a normal lifestyle, but some may need psychological support for stress or anxiety resulting from chronic symptoms before diagnosis. Genetic counseling and family education are beneficial in hereditary cases to help family members recognize symptoms early. As with management of any disease or condition, PCC patients can increase their life expectancy and quality of life with a healthy diet, regular exercise, and continued follow-up with healthcare professionals. Thank you. And here are my references.